Mr. Chairman, dear colleagues, dear friends, sisters and brothers in stone. First of all, on behalf of International Alliance of Urologiasis Executive Board, it's a great pleasure for us to present this presentation, and we are grateful for the organizing committee for inviting us and for organizing this great event. We wish them success. I'm sure it will be a great success. Over the next 15 minutes, I will try to focus on the surgical and medical management of stones in children. Beginning with surgical management, we know all available options in adults can be applied now in pediatric cases, namely shock wave lithotripsy, ureteroscopy, PCNL, and in selected cases with anatomical abnormalities and large, highly complex stones, maybe open surgery. Beginning with shock wave lithotripsy, we know that this modality represents the most favorable one, successful one, acceptable one in this specific population, with some certain advantages when compared with adult cases. We know that children pass stone fragments well, and they do not require routine standing. IV sedation in older children may allow a safe and successful treatment. Newer generation lithotripsy with smaller focal zones will allow a less painful shock lithotripsy, and more importantly, we may expect better stone fragmentation and stone-free rates due to the shorter duration of stone disease, greater stone fragility, lower impedance to higher shock waves, and early mobilization in these cases. When we evaluate the guidelines on this aspect, we will see that shock wave lithotripsy will represent the treatment of choice in the majority of stones in kids, including kidney stones with smaller and moderate size, and also including lower pole stones, again, upper ureteric stones, mostly sizing less than 1.5 centimeter, let's say. When we evaluate the published data so far, as we see here, if the stone size is less than 1 centimeter, highly successful data, reaching 100% stone rates could be anticipated. This is also valid for stones larger than 2 centimeters. Unlike the adult cases, really acceptable stone rates could be expected and seen in these cases. This is a nice study summarizing the high-energy shock wave application in kids, and overall success rates range between 70 to 100%. Even in Stockholm calculi, we may have really acceptable outcomes, and lower pole calculi is also another location for the stone treatment in kids with successful results. How about complications? This is also another nice study summarizing the complications. Total number of studies 20, and as we see here, stone burden is the main task related with the complications, and majority of the complications, including hematuria, are minor in case and evaluated in Clavien-Dindo stratification. How about the ureteric stones? Again, studies do show that highly acceptable and successful stone rates can be anticipated in kids also due to the smaller and shorter ureteric and more elastic characteristics. They will pass the stones easily in a practical manner, and stone rates, as you see here, really higher and acceptable. Retreatment rates could be higher when compared with the other modalities. When we take the non-invasive nature of this modality into account, it will be the treatment choice. How about ureteroscopy in kids? We know that in the beginning, it had a delayed adoption in this specific population due to the use of large instruments in the beginning, higher fragment clearance after shock wave lithotripsy, and lower incidence of stone formation in, say, children. It affect or prolong the use of ureteroscopy in this population. But over time, we know that techniques refined, equipment improved, and we now have highly fine, miniaturized equipment to use in this population, and also durability of the equipment increased. Holmium laser began to be applied like in adults, and most importantly, experience coming from the adults increased and allowed endourologists to perform ureteroscopy in kids also. Evaluating the data coming from 15 studies, if the reasonable number of cases, stone-free rates in stage procedures can come up to 100% in these cases, and major complications, as you see here, are really less as compared with adults, and they are acceptable. On the other hand, if we go through the guidelines again, evaluate them, we will see that ureteroscopy will be the treatment of choice for lower ureteric stones in kids. Over time, flexible ureteroscopy, depending on the experience gained in adults, also begin to be applied in kids. Although the number of publications are really limited when compared with adult cases, but we may see that the stone-free rates, success rates are really acceptable, high enough if we select the cases very well and if we use appropriate instruments. Regarding the use of excess sheet, it's not necessarily, we need to be highly careful, as we see in this study. Complications could be higher if the stone is complex. If we need to use it, if the procedure will be a long-lasting procedure, we may use it, but otherwise, use of excess sheet is unlikely or not needed in the majority of the cases. Flexible ureteroscopy in preschool age children, a study coming from Turkey, my friend Dr. Erkut and his colleagues did evaluate the 65 cases, children, and here you see mean stone size. Stone-free rates were after first procedure around 83% and 92% after second procedures. It's an effective safe procedure, and the claving and endo-based complications were minor in nature to be accepted easily. RIRS monotherapy versus shock lithotripsy in medium-sized stones, again in preschool children, when the author evaluate both procedures, in the end, they were able to show that both are acceptable. After a single session, shock lithotripsy stone-free rates are really high and acceptable. Operative time is a little bit longer for RIRS. Radiation exposure could be a little bit higher for shock lithotripsy, but mean hospital stay and complications will be evident for ureteroscopy. How about the use of ureteroscopy for upper ureteric stones, lower and upper ureteric stones? Again, acceptable stone-free rates with high success rates could be anticipated in kids, again, depending on the stone and patient-related factors. Guidelines regarding the use of flexible ureteroscopy do show us that for pelvic stones and also for lower pole stones, if we select the kids very well, this modality will be highly successful and effective in children also. The last part of the surgical presentation will be PCNL in kids. We had in the beginning some concerns regarding the long-term renal damage from the growing kidney of the child, smaller kidney size, use of relatively large instruments, radiation exposure, and major complications were the concerns to be kept in mind in the beginning. And indications were really similar as in adults: larger stones, partial complete second stones, lower calcium stones, and strobite cystine stones were the indications for PCNL. And guidelines, again, do let us know that we need to use this modality in larger stones, second stones, for pelvic stones larger sizing than 2 centimeters, and also larger lower pole stones. Studies do show that if we select the cases very well, stone-free rates will vary between 68% and 95% or 98%, and complications really are minor in nature as seen in adults. In the beginning, we used larger instruments, and over time, miniaturization procedures take place. In this study, the authors did evaluate the efficacy of miniaturization, and in cases in children treated with relatively smaller instruments, there were no complications, no transfusions, and with higher acceptable stone-free rates. Mini PCNL in kids, including stack-on stones, is the method of choice now to harm the kidney to a limited or no extent. And as we see in this study, the authors in large and complex stones did get a 83% stone-free rate, with an increasing success rate when treating the residual fragments also. The others did evaluate the efficacy of retrograde incisional surgery and mini PCNL in children in a comparative manner when they treated stone sizing larger than 2 centimeters. As we see here, a mini PCNL will reveal higher stone rates and complications will be also evident and higher in these cases. Mini PCNL for larger stones, stone sizing less more than 2 centimeters, is a treatment of choice nowadays in kids. When we evaluate the mini PCNL, miniaturized PCNL procedures, we have ultra mini PCNL using 13 to 14 French armamentarium, and in this nice study, in treating the stones larger than 2 centimeters, including the lower pole stones, this modality could be the treatment of choice for kids for a less invasive procedure. Super mini PCNL, defined by my dear friend Professor Zeng from China, another different mini PCNL procedure, 7 French inner sheath, and from between 10 to 14 French nephrostomy tract they are using now, and totally tubeless procedure is possible. The main features of this procedure is active irrigation and active suction in order to get all fragments forming during the procedure out and have the pressures inside the kidney acceptable and less. And in the end, when we evaluate the data coming from 4 different centers by using super mini PCNL in kids, 111 pediatric stones, and in the end, we see that the success rates are really acceptable and high, and stone free rate at 1 month is around 97%. Totally tubeless PCNL will be around totally tubeless 70% in these cases. That's very important because we need to be as less invasive as possible. MicroPERC was another procedure to be applied, but it was not, it couldn't be popularized so far because we know that we disintegrate the stone in the kidney, but no stone particle will come out, and that was the most important drawback of this modality, and it has not been popularized. There are no, let's say, highly limited outcomes reported in the literature. That's a study coming from my country again. 19 children were treated with this modality. In the end, around 90% stone free rate have been seen, and the complication rates were really acceptable and less. Which technique shall we use? In children, the indication for shock wave are similar to those adults, we know that. And for larger stones, we need to use PCNL in order to render all these cases stone free. Last but not least, when we evaluate medical management in this specific population, beginning with calcium-containing stones, we know that increased fluid intake is a must, dietary modification is mandatory, and calcium, animal protein, and sodium need to be well assessed. Dietary sodium restriction is recommended. Maintenance of calcium intake is a must, and we know that any recommendation to restrict calcium intake below the recommended levels should be certainly avoided in these cases. Hydrochlorothiazide and other diuretics could be used in cases with hypercalciuria, particularly with renal leak type, and this is the dosage. We need to titrate depending on the outcomes, and we need to know the possible complications during the application of these agents. Citrate therapy is also useful if the citrate level is low in these cases. Coming to hyperoxaluria, promotion of hyperurine flow, restriction of dietary oxalate, and regular calcium intake are the measures to be taken. In mild to moderate cases, pyridoxine has been used with a certain successful outcomes noted. Hydration and additional citrate therapy is also recommended in these cases. The dosage of pyridoxine is being presented here. Citrate administration may increase the inhibitory urine activity, but in severe cases, in the past, we know that hepatorenal transplantation due to the oxalosis, severe oxalosis, were needed. Luckily, we have a successful agent, lumasiran, for use in these cases in order to lower the excretion of oxalate in these cases, and this agent is being used with highly successful outcomes. And as in this study shown, the reduction in lumasiran group, the urinary levels of oxalate reserve was around 66%, and 84% of the cases had urinary 24-hour urinary oxalate excretion no higher than the 1.5 times upper than the normal limits. Hyposteroidism, if we detected in metabolic evaluation, potassium citrate could be applied in these cases, starting with a dose of 1 milliequivalent per kilogram. Side effects need to be kept in mind, and potassium citrate need to be used if the kid has lower citrate levels. Uric acid stones, alkalization of the urine is the mainstay of the therapy. Like in adults, pH of the urine should be monitored to bring it to the dedicated levels. And if the cases are sustaining hyperuricemia and hyperuricemia, allopurinol could be used as another agent to lower the excretion of uric acid. Cysteine, when we deal with this cysteine stone, the initial treatment consists of maintaining a high urine volume, and alkalinizing agents need to be used to bring the pH of the urine up to between 7 to 75, 7.5 values. Use of theophylline or deep penicillamine may increase the cysteine solubility if general measures are not successful or inconclusive. But we need to know about side effects, particularly for the penicillamine. As I stated, theophylline could be used. Dosages here for severe cases in order to limit the excretion of cysteine. How about infection stones? Primary objective is the complete elimination of all stones without leaving any fragment. If renal anomaly is causing the stasis, it should be targeted and treated. Use of urease inhibitor is really controversial, even in adult cases. Care should be taken. Eliminate urine for urine acidification is not recommended. Intake of cranberry juice may be recommended for these cases, and also antibiotic therapy, long-term prophylaxis is the major test for us in treating these stones. To conclude, I may say that technological advances in shock ureteroscopy, ureteroscopy, and PCNL have had a significant effect on the management of stones in children, allowing a safe and successful outcome. Minimal invasive techniques should be used to treat stones in children because of the greater probability of stone recurrence than in adults. Due to the small body habitus, delicate tissues, and possible long-term complications, proper and detailed planning of the surgical procedure is of utmost importance in this specific population. Despite the consensus of shock ureteroscopy being the initial treatment in the majority of the cases, depending on stone size-based manner, there are certain definite indications of endoscopic indications in kids. We need to use them either alone or in combination, but general measures are also valid for all children with stone disease. Carefully planned and closely followed medical management alternatives will be effective in selected cases. Open surgery is currently necessary in few selected cases. Thank you very much for your attention, and greetings from Istanbul.